Welcome, and thank you for attending our webinar. I have some housekeeping notes before we begin. Because of sound quality, it's necessary to keep you muted throughout the program. You have the ability to ask questions using the questions box on your control panel. As a provider of continuing education, ICS follows specific guidelines and regulations when presenting continuing education events. We appreciate your professionalism and honesty in accurately recording the number of CE hours you attend during any given program. We recommend you be on the webinar screen for the full webinar. The system can tell if you pull up another screen, such as your email, and show you as inattentive during that time. ICS bases the amount of time you're attentive when considering your CE hours. Polling questions are asked during the webinar. They are also used to gauge your attendance in CE credit hours. You must have your pop-up blockers turned off or hold down your CTRL key in order for the polling questions to work properly. If the polling questions do not function for you, simply write down the question and your answer and fax or email it to me, or type your answer in the questions box. An online survey will display on your screen when you leave the webinar. Please take 30 seconds to provide us with valuable feedback. Today we welcome Dr. Ted Arkfeld to assist us in implementing ICD-10. This is a 2-hour webinar and the second in a series of 4. We will be taking a 10-minute break at about 1:30. Dr. Arkfeld has been experiencing some connectivity problems from some storms he's had in his area. So if all of a sudden you lose the screen or you lose Dr. Arkfeld, he's able to resolve it quickly. It should just take 30 seconds to a minute for him to come back on. So just wait patiently. I'm still here. It happened while we were practicing. So I'm still here. You can type into the questions box and ask if I'm experiencing the same thing you are. So hopefully that won't happen, but just in case. Dr. Arkfeld graduated from Northwestern College of Chiropractic in 1988. In 2007, after being in clinical practice for over 19 years, he became a certified professional coder and full-time compliance consultant. In the fall of 2010, Dr. Arkfeld and Genius Solutions launched the National Academy of Chiropractic Coders. This is the first national organization to provide education and a certification for doctors of chiropractic and their insurance staff. He has also authored 2 textbooks and is a much sought-after speaker for state conventions. Join me in welcoming Dr. Arkfeld.
Thanks, Denise, and welcome back, everybody, to session 2 on our journey into ICD-10. Today we're talking documentation. This is going to be a major aspect of transitioning to ICD-10. Last week I believe I mentioned that it will not be enough for the doctors just to learn how to translate ICD-9 into ICD-10, but your documentation is going to drive that. So we're going to get into that a lot today over the 2-hour period. And we have our ChiroCode endorsement here, and again, the ICD-10 coding for chiropractic is a must resource in doing this translation over into ICD-10. So where do we start when we talk about documentation? And in attending seminars and conventions over the years, and over 25, 26 years of being a chiropractor, over the past few years there's been more emphasis on documentation. And I'd go to seminars and I would hear, well, you have to document better. Make sure you document. And what's lacking, I think, is what to document. And many times I get the question, well, where's the rules? Where's the resources? Who's telling us, or where's the guide on proper documentation? And it all comes from the Medicare publication as it relates to chiropractic. They have specific documentation requirements that we need to follow. There's also in the CPT code book for our examination procedures. Those are all based on documentation. So whatever level of evaluation and management code you're going to select for your new patient or established patient visits, those are directly related to the documentation, and that's how they are substantiated. So where do we start? Well, let's get to the essentials. And what I've done is kind of molded both the CPT requirements and the Medicare manual requirements because they mimic each other very closely. So the first thing you have to do is you have to have the chief complaint of the patient. Okay, so the chief complaint is going to establish what new patient or established patient code are you going to choose. Now, I know this is about ICD-10, but we need to get into fundamentals right now. And so these are the basics that you can start in your practice right away tomorrow. Okay, so you don't have to wait till ICD-10 comes into play October 1st or 2015. Let's start using these things right now because we don't want it to be a last-minute rush to transition over on October 1st. Let's make sure that we have everything in a row, our ducks in a row, so we're ready to go. So the chief complaint of the patient, and then the causation. Now the mechanism of injury is a huge factor in ICD-10. As you'll see later on when I get into some examples, there are specific codes. There's a whole chapter purely on mechanism of injury, and they go into things like if you were in the kitchen and you had a pot, fall and hit your head, creating a concussion, or motor vehicle accident injuries. If you're the driver of a pickup that was rear-ended by a semi-truck, these are specific details that will go for the etiology diagnosis in ICD-10. We need to have a past medical history because that can also affect the codes that we're going to use for ICD-10 as well. Review of systems and family and social histories. These are all part of the history process. Obtaining a thorough history is arguably the most important component of a new or established patient encounter, and it is probably the most informative diagnostic tool a physician possesses. After you've been in practice for a while, patient comes in, presents with a history, you're already thinking, hey, I've seen this, I know what's going on here, and then you do your examination to confirm it. Let me give you an example. I happen to have a new patient in last week, and he came in with what he describes as nasal and respiratory episodes, where all of a sudden he just feels like this cold blast, like he went from a 75 to 80 degree day into a walk-in freezer of sub-zero. And then he has both his forearms, they go into a spasm and a real deep ache. So I'm going through this history, and we did the exam on him, and everything was negative from a musculoskeletal standpoint. But years ago, I had treated a welder who had had toxicity poisoning, environmental toxins from the byproducts of the welding material. And he had these weird neurological complaints, these parasympathetic and sympathetic disturbances, and this history just triggered, his history triggered, came back up when I was taking the history of the new patient, and I was thinking, hey, maybe there's an environmental process going on here that we're not aware of. So anyway, the history is so important because that history is going to drive, again, the code for the new patient exam and your need to obtain the mechanism of injury. Causation plays such a vital role in a lot of auto cases, workers' comp, and now with our Medicare as well. So the history is the starting point for determining the correct evaluation and management level to bill and code. And in today's healthcare, history takes on even a more important role. It can determine medical necessity issues. And so the documentation on medical necessity by Medicare states that a person must have a neuromusculoskeletal condition and that the subluxations are anatomically related, causally related, and that they need care. Okay, so in your history, in your subjective complaints, you have to have enough elements to substantiate the need for maybe a 3 to 4 area adjustment or a 5 area adjustment. You know, it's interesting. I had a doctor from New York contact me and state that their carrier was going to start doing prepayment reviews on 98940 codes, their Medicare Part B carrier. And that he showed me a list of states that are supplied by that carrier and the error rates. And like Upper New York state was 91% coding error rate. Connecticut was 87% error rate. And so the carriers are taking a closer look at all this. All right, so the best way to build a defense is to take the proper history. There is a building block. There's stepping stones here. And the first one is history. Then we're going to come to the examination. From the examination findings, we're going to find the most appropriate and specific diagnosis codes. And then from those codes, we're going to come up with the most research, evidence-based treatment plan. So we're talking more than just ICD-10 codes here. We're talking about the whole case presentation and making sure your case file is rock solid. There are two main references for the history, and again, CPT Codebook and the Medicare Manual for chiropractors. CPT Codebook requirements are chief complaint, and then a history of present illness, or what we call HPI. The history of present illness has 8 elements, and that very closely resembles our OPQRST that we were taught in chiropractic school. Onset, site, severity, what's the quality of the pain, sharp, dull, achy, what's the pain scale on a scale of 0 to 10, what makes it worse, what makes it better, what is any modifying signs or symptoms. And so these history requirements, history of present illness, these are all molded into the Physician's Quality Reporting System as well, or PQRS, that we're asked to participate in now with our Medicare Part B patients. And so there's 3 different measures that are coming out, or that have come out now for 2014. And the first measure is you must have a pain scale on your Medicare Part B patients. And then you must have a clinical outcome assessment, or they call it a standardized tool for another measurement on functional outcomes. So that's your neck disability and your Oswestry revised outcomes. And then there's another, the new measurement is a blood pressure for this year. So all these documentation requirements kind of blend in to one another. All right? So even when you get into the stimulus program for EHR, it's asking you to obtain certain pieces of data. Well, one of those is you must have a subjective complaint, or there must be complaints on a patient for meaningful use data. Another one must be medications and allergies to medications, which would be our past medical history. The other aspect to meaningful use would be our vital signs and smoking and tobacco use. Okay, so all these things that are coming together with the changes in healthcare, they all have a common theme in them, and it actually is taking a very good history and documenting better. Review of systems. We have 14 systems, and we're going to, based on the presenting complaints of a patient, we're going to ask on how that condition is affecting anatomically pertinent review of systems. For example, if they have low back pain, what effects on the genital, urinary, or gastrointestinal systems? Are they having stomach problems? Are they having bowel or bladder dysfunction? So when you apply the review of systems, you may possibly be able to code to a higher level of E&M code. And finally, the past history, including past medical history, family history, and social histories. So per Medicare requirements, what are the symptoms causing the patient to seek treatment? And the symptoms, you must have a symptom for every area that you're going to treat. So if you are a full spine adjuster, you have to have symptoms in the cervical, thoracic, and lumbar spine to validate a 98942 area of adjustment. Correspondingly with that, you must have subluxations found in cervical, thoracic, lumbar, SI joints, and sacrum to do a full spine adjustment. And those symptoms must be causally related to the subluxations that are found. Okay, so family history. You know, they want to know, Medicare would like you to ask, is there a history of diabetes? Is there a history of arthritis? Is there a history of cancer? You know, or what other history that could possibly affect or be relevant to the presenting condition of the patient? Past health history, they want to know about prior illnesses, injuries, hospitalizations, medications, and surgical history. Now, the past injuries, we could possibly use some codes, our traumatic subluxation codes that we talked about last week. If you remember, we had the episode of care for our traumatic subluxations. A was going to be the initial encounter, so anytime on the new patient visit, you're going to use A for that, or with a re-examination, or let's say it was an established patient that was returning to your office with a new injury, you would use A on that first claim form. And then you had a choice of either D for subsequent visits or S for sequela. Well, sequela is residuals left over from maybe a prior illness, maybe a prior injury. Right? So it's real important that we take a good, thorough past health history, because we may be using the S, seventh character, on our traumatic subluxations. We also want to talk about the quality and character of the symptoms, the onset, duration, intensity, frequency, location, and radiation of symptoms. You know, one of the things is the pain scale, and what I find really important is that when you ask initially, when the patient is coming in, on a scale of 0 to 10, what's the pain scale? And if they say, well, it's an 8, and you say, okay, what's the timing of that 8? And they say, it's constant. You know, I'm really struggling. I'm pretty much laid up in bed because I just can't do anything. Well, as you start your treatment, the patient may come in and say, you know what, I'm still an 8, but it's not constant anymore. It's down to frequent or occasional. And that's important for you to document, because that's establishing that your treatment is effective. We just took a patient from a constant 8 down to occasional. Right? So these are the kind of the documentation requirements that is going to help build medical necessity and also help with your ICD-10 selection as well. We're going to talk about prior interventions, treatments, medications, and secondary complaints. And again, these prior interventions or these medications, that goes to satisfy your stimulus, meaningful use information with medications and allergies to medications. Mechanism of trauma, I could have a whole 8-hour seminar just on mechanism of trauma. You know, mechanism of trauma, we were taught very well in chiropractic school how to recognize and diagnose various acute injuries and chronic injuries. But what we weren't taught is the biomechanics behind that, the loads that are responsible to cause that injury. And mechanism of trauma is becoming very important, not only for our auto and work comp, but what about household injuries? What about our Medicare patients? that have started out with care. You release them, they're doing well, and maybe they re-injured themselves. Now they're raking, maybe they're doing a lot of garden work. You have to document about the mechanism of injury. Causation is absolutely huge in all areas of healthcare. We also want to talk about aggravating or relieving factors. So these all come right out of the Medicare manual. So documentation requirements now on subsequent visits. For our SOAP notes, we need to review the chief complaint or secondary complaints. We need to document what are the changes since the last visit and also talk about any system reviews if relevant. Our physical exam is our objective. So with our SOAP note, we have the subjective, which we're going to talk about all the review of the complaints. With your daily notes, I recommend, and this comes from helping doctors in post-payment audits. So it is really, really a strong defense with your daily notes if on your subjective, not only do you have a review of the chief complaints and how they're progressing, but you also have a pain scale. And if you can always tie that back in to a loss of their normal activities of daily living or how that is progressing. So let's say that you had a patient that was coming in. They started out as a constant 8 with low back pain. A couple weeks into care, now it's down to occasional 8, but that occasional 8 is when they sit for 2 or 3 hours in the car. When you can relate it back to an activity of daily living, that is very, very powerful, and that really bolsters your defense that your treatment is medically necessary. Now, number 2, our physical exam. Our physical exam is going to be our objective area, and we need to put in any tenderness. Well, basically, we do a part exam on every visit as a chiropractor. And I know that a lot of offices say, well, what's this part exam? They get really confused or they get a little anxious about the part exam, like it's just some big separate examination process that they have to go to. It's what we do every time we see a patient. We come in, we palpate their spine, we document areas of tenderness or pain, which P in part stands for pain. We document any areas that are fixated, subluxated, whether you use listings of right rotated or right fixated, or you just put C6 is fixated. That is the A in the part exam. That's asymmetry. We have to document asymmetry or the subluxation. Okay, and then the T is tissue or tone changes in part. So we need to document, is it hypertonic muscles? Is it spasms? What are we feeling there? And if it's hypertonic, that's going to be one code. Right now it'd be 729.1. If it's muscle spasms and you say the word or document spasm, that's 728.85. So again, there's very specific codes based on your documentation findings. Okay, so you're going to have the pain, the subluxation, the tissue. You may also want to document if they're having difficulty transitioning from one posture to another, if they're having difficulty going from a sitting to a standing, if they come in and they're still antalgic. Anything you can put into that objective that's going to tell the story of how the patient is responding to your care is going to be great. And then we have also the assessment area, or A, in our SOAP. Now this is an area that I see is not documented very well, and I think we get busy and we may get a little lazy sometimes. I'll see documentation that the patient is in the acute inflammatory stage, on visit 1. I'll see the same notation on visit 40. And then you go through and see that it's on every visit between 1 and 40. The patient is not in the acute inflammatory stage from visit 1 to visit 40. The doctor didn't change the assessment. The assessment should be patient improving as anticipated, progressing as expected, unchanged. If it's unchanged, call it like you see it. It's unchanged from the last visit. There's slow improvement, steady improvement, or if there's been an exacerbation, You document that as well. Underneath the assessment, well, actually in my notes above the assessment, I list out the diagnosis, and I highly recommend you do that in your SOAP notes. Have the diagnosis in your notes. And then we have the P for the plan, and that's the documentation of the treatment given on that day of visit. So you're going to state patient received a 98941 3 to 4 region adjustment. It's okay to list out your technique on there. That'd be more for you than for anybody else. And then list out the areas that you treated, and that must correlate, number one, with the subjective complaints of the patient, and then it must also add up. So if you're doing 3 to 4 regions, a 98941, you better have cervical, thoracic, or lumbar documented. You must have 3 to 4 regions documented where you did the chiropractic manipulative treatment. Also, if you are doing massage therapy, put the time and what muscles that the massage therapy was directed towards. If you're doing active rehabilitation, make sure that you just don't put the code like 97110 down. You need to put down the time spent. Those are time-based codes. So put the time spent, put what exercises the patient performed, and if there was repetitions and sets, document that along with the weight or the color of tubing or whatever they were using. And it would be also okay to put in there how the patient did with that. So what I'm getting at here is that these documentation requirements, for one, have been around for a long time. These are not something new. Medicare's had these for a long time. Number two, I talked, I believe, last week about the need to transition into electronic health record system. You cannot keep up with the documentation requirements, and especially going into ICD-10 with travel cards or handwritten notes. That is going to be an impossibility if you want to see any kind of volume. I mean, if you're seeing 5 patients a day and you're happy with that, and you know that's about all you could keep up with, I think, using a paper system. So electronic health records are going to be a must. So now the chief complaint. It's a concise statement describing the symptoms, problems, conditions, or other factors. It's the reason the patient comes in to see you. And that chief complaint, the reason you have to get that documented, because that's going to go in the A slot. I almost said 1, thinking back to the old claim form when we just had 1, 2, 3, and 4. And now it's alphabetical, and there's 12 slots. So the chief complaint diagnosis is going to go in the A slot, and you're going to have all the diagnosis related to that chief complaint, so that could fill up 3, 4, maybe 5 slots on your claim form. And then your secondary complaint is going to go next, and then your tertiary complaint is going to go next. What I want you to get away from if you're doing full spine adjustments is just listing out all subluxations. 739.1, 739.2, 739.3, 4, and 5, and then putting like a pain diagnosis. Let's get real specific, and we're going to talk about that today. One of my favorite topics is what we're going to talk about the second half today, and that's the vertebral subluxation complex. And now you need to remember, I graduated from Northwestern. Now, I love my education from Northwestern. I love the school and everything. I think I got a quality education. Philosophically wise, we didn't have as much in that area as other schools. And when I graduated and got out and started practicing in Arizona, I learned real quick from an insurance reimbursement standpoint the use of the 739 or 839 codes as a primary diagnosis was not going to help with the number of visits I was going to need and sometimes the reimbursement. So quite honestly, I abandoned using the subluxation. And there was a lot of things associated with that too that I struggled with, trying to mold a medical code with our subluxation. I mean, do I know we treat subluxations? Absolutely. And I've come really full circle now and really have more of an appreciation of exactly what we do treat when we treat the subluxation. So the second half of this, I'm going to show you how your orthopedic and neurological exams validate the existence of components of the subluxation complex. And I guess my challenge to you now is to think in more detailed terms when using a subluxation. So we're going to use a general subluxation of 739, or if it's a traumatic subluxation, 839, but we're going to break that up into the components, the various 5 components of the subluxation complex. And so I love teaching that aspect in the documentation. A few years ago, I read in Dynamic Chiropractic a very, very well-known chiropractic authority, and I'm sure I'm not going to name who it is, but they came out and said that orthopedic and neurological tests do not validate the existence of the subluxation. And I absolutely disagree with him. If you document, if you interpret the orthopedic and neurological tests correctly, they absolutely validate the subluxation and what we're treating. And so we're going to get into that later on as well. So once the chief complaint is solicited, next is the mechanism of injury or trauma. So you need to ask them what caused the problem. And it would be a good idea to put the mechanism of injury is the patient was cleaning out their garage during spring cleaning, picking up 45-pound boxes repeatedly. Or I got to tell you, Monday I woke up a little sore in the low back. I spent most of Sunday on the riding mower, dethatching and then mowing the yard. So these are types of activities that you should be documenting. So the history of present illness, first of all, you need to document the location or locations. When you document the chief complaint, and let's say that is low back pain, and then there's a secondary complaint of sciatica. I think we went over this last week, is that there is laterality now with extremities. There's right, left, and unspecified. When you're doing your history on every complaint, be sure and follow the history of present illness for all the complaints. Too many times in reviewing case files, I have come across patient presents with neck pain and right arm pain. And then the doctor goes in and documents everything about the neck pain, but that was all he mentioned about the arm pain. So for any complaint, you should do an HPI for every condition. So where was the arm pain? What kind of pain was it? On a scale of 0 to 10. Where is the pain? Does it go into the last 2 fingers of the hand? Well, that's going to have a different, possibly a different anatomical structure representing that than on the thumb or first finger. So make sure that you document everything with each complaint. What's the quality of pain? Sharp, dull, achy, throbbing, stiff, sore. And severity. On a scale of 0 to 10, how bad is it? Duration, how long have you had it? Timing, occasional, constant, frequent, intermittent. Context, in what context does the pain present itself? And modifying factors, what makes it better? What makes it worse? And are there any associated signs or symptoms with this complaint? So again, for every complaint, make sure that you do the history of present illness. Now, in order to meet or exceed the documentation requirements for evaluation and management codes, those are based on how many of these 8 elements that you document. I always recommend that you document all those elements for when you're seeing a patient. Just take a very thorough, good history so that you can exceed the documentation requirements for the history. Evaluation and management codes are a huge revenue loss in chiropractic. And again, I could spend another 2 to 3 hours talking about that. Now, when you're asking about a scale, a 0 to 10, we're dealing many times with psychosocial factors. And the best example I can give you is years ago when I was in practice in Phoenix, Arizona. I wasn't too far from Luke Air Force Base in Sun City, and I was seeing a decent amount of World War II veterans. And I remember one gentleman came in, and I said, you know, well, where's your pain at? And he goes, well, I'm not in any pain. And I said, well, you know, what brings you in? And he goes, well, I have some stiffness and soreness in my neck. I said, well, that's pain. He goes, no, the pain is the shrapnel that's in my leg. That's the pain. This is just stiffness and soreness. Okay, so we, in order to establish medical necessity, not only for our exams, but ultimately our treatment, we need to pick up on this. We need to be able to give the patient enough information on what we're trying to achieve with this history process so it's a success. So at times, we may have to dig a little deeper and become a very good historian on this. So again, many times patients, based on, and when I say psychosocial, what is their background? Obviously, you've had patients come in and they tell you everything, you know, a lot more than what you probably really wanted to hear. And at other times, you have patients that are extremely stoic and you can't hardly elicit anything out of them. Right, so this is what I mean. We've got to be acutely aware of this and be able to become a very good historian. The review of systems, a lot of times you can get this from your intake forms. This will be satisfied on your intake forms as long as you document that you reviewed this with the patient. And these are the 14 systems as per the AMA CPT codebook. You know, so when we're seeing somebody with a low back, we're going to be asking about gastrointestinal, genital, urinary, a cervical or headaches, eyes, ears, nose, cardiovascular, neurological. So we can dip into a lot of these here and see how these systems may be affected because of the chief complaint or complaints of the patient. Past medical, family, and social histories. You know, again, we're going to ask about surgeries, fractures, traumas. So you see how this really mimics the Medicare documentation requirements for an initial visit history. And I need to make one thing clear regarding the Medicare documentation requirements. When I say initial visit, that does not mean when the patient first came to your office. The document or the manual specifically states initial visit. That is going to be an initial visit even if they came back for a recurring condition. So it's the initial visit for that treatment plan that you may be putting a patient on. So if you have a patient that had established with you and you initially did the new patient exams and you did the history and everything, let's say that patient was released from care a couple months ago and now they come back in. When that initial visit, they may have a new condition. It's the initial visit for that new condition or that exacerbated condition. Family history, again, we're going to ask about diabetes, hypertension, cancer, arthritis. And now we get into the clinical examination part, or the physical. All right, so our history is going to determine what is the examination that we're going to perform. Okay, and Examination forms, they should only be guides or templates for performing the evaluation. They shouldn't be a crutch, or there shouldn't be a cookbook approach to the orthopedic assessment. So what we need to do is do this all in what we call a flowchart differentiation manner, with tests and counter tests to lead the examiner to the real cause of the problem. Our primary goal as physicians is to determine what are the anatomical sources of pain in the muscular or neurological systems, maybe even visceral somatic. So the anatomical sites of pain are, one, discogenic. We now know that the disc, when flared up, can cause a lot of back pain. It can be, two, facet-mediated pain. We know the facet joints are highly innervated, and when those things are irritated, they can cause a lot of pain. Dorsal root ganglion, or DRG, that's our nerve pinch. So the dorsal root ganglion is comprised of 70% sensory fibers, 30% motor fibers. So in order to substantiate a neurological diagnosis, we need to do a neurological evaluation of at least motor testing and or sensory dermatome testing. Then we have myofascial syndromes that can cause pain or be the anatomical source of pain. And then finally, visceral somatic. Even I would say there's probably a sixth one too, chemical mediated pain. We also now know that when the disc is irritated enough, it can produce a chemical response. Or if there is a herniation, the nucleus pulposus, that's not recognized by the rest of the body. And when that creeps out and starts irritating, then we have an autoimmune. Things are going to start fighting that. So we get a chemical response. So I used to just teach the 5 anatomical sites, and I'm starting to talk about the chemical, the chemical inflammation caused by what we eat, or chemical radiculitis by the irritating substances that are irritating the nerve tissues. Okay, so our goal...
Dr. Arksfeld, we do have a question.
Sure.
Please give an example of context in the HPI.
Okay, let's see here. Context of the HPI. Okay, the history of present illness. All right, so the patient presents with the chief complaint of low back pain. So the first of the HPI would be location. And that's where the patient's pain is, the location of the pain. So they'd say the patient points to just right of the midline of L5. I would say the patient, the pain is in the right L5 area. And then we're going to have quality. It's sharp stabbing. On a scale of 0 to 10, the patient states that it is really affecting a lot of their normal activities of daily living. And so I give a higher number to that. And I'm actually glad that you brought this up. When we get in dealing with pain scales, make sure everybody in your office is on the same page. Now, what happened when I was practicing at the chronic pain clinic, the very first day I had a patient come in, and those patients were all very well educated about the pain scale. And so the patient came in and he sat down very comfortably. He walked in with no difficulty at all. He had no facial expression of any kind of distress or pain. And I said, on a scale of 0 to 10, where's your pain today? And they said, I'm a 10. I said, okay, 10 is the worst. 0 is no pain, 10 is the worst. Yeah, I'm a 10 today. And I said, you can't be a 10. Well, why not? Because you're not in any distress. All right, so then the patient said, well, yeah, I just took my Vicodin or Oxycontin or whatever I was taking, but normally I'm a 10. Okay, so be very careful on your pain scales. And what I do is I equate the pain scale, because quite honestly, it gets to be a real hassle. Well, Mrs. Jones, what's your pain today? Oh, it's an 8. What are we basing that on? You know, we're basing that really on a subjective response from the patient, right? Well, I want to try to get to more objective measures. I want to try to take and objectify her subjective response. And the way that I do that is I equate it to activities of daily living. We know that when we are very sick, or, I mean, I had kidney stones a couple of years ago. I didn't want to do anything. That was a 10. You know, I was flat out in bed. And so those are true 10s. So when your activities or those patients' activities are severely limited and they are just getting up for bathroom privileges, that's an 8, 9, or 10. When they can perform some minor activities of daily living, let's say when you have a bad case of the flu, you can make it out to the couch to watch some TV, you know, that's probably a 6 or 7. So equate it to the activities, and I think that'll help with objectifying their subjective response. It gives them a better idea of what you're looking for, and it also, if you're in a group setting, and this was the other problem when I was practicing in the multidisciplinary setting, the patients would come see me first. And I'd say, well, what's, you know, on a scale of 0 to 10, what's your activities and all that? And they'd say, well, I'm a 4 or 5 today. And they would be scheduled to go see the MD across the hall. Maybe they had to get a new script refill. Well, in the 10 minutes after I saw them, before they were seen by the MD, and the MA would ask them what their pain scale was, all of a sudden it's up to a 6 or 7. All right, so now if we were ever to be audited, that could have really caused some problems because there was such a discrepancy from when they saw me. And no, I didn't hurt them. For those of you who are thinking, well, you know, what was Ted doing? No, I didn't hurt them. They were just, we didn't have a good firm definition of the pain scale down. Okay, so that's the severity. Then, what makes the pain worse? What makes it better? What activities aggravate it? What makes it better? And is there any other things associated with that? So the history of present illness, it's really the OPQRST that we were taught in school. Onset, site, provoking, palliative, timing, duration. They just call it the history of present illness for the CPT code book. Did that answer your question?
We'll see. Yeah, we'll have, if the doctor that asked that question could let us know, yes, it answered it.
Okay,
We
good.
got another question from that, though. What pain scale do you use for children, and how do you document their problem in HPI? And would it be okay if I did the polling question while you answered this one?
Yes, go ahead.
Okay, so if everyone will hold down their CTRL key, I'm going to launch the first poll now. If it didn't pop up, I'm sorry. If it didn't pop up for you, you can type the answer in the questions box, email it to me, or fax it to me. Okay, go ahead.
Okay, so to answer the question, how do we do this when dealing with kids? Because obviously, they're not going to come in, except I do have to tell you this story. You know, this is how well chiropractic, the sons and daughters of chiropractors are trained. I have 2 daughters, and when my oldest daughter was about 10 years old, she fell out in our driveway rollerblading. Came in holding her elbow, crying, and I said, you know, what is it? What is it? Well, I'm trying to find out where. I just see a crying kid coming towards me, and she holds her elbow up to him, and she goes, "It's a 10, Daddy, it's a 10." You know, that's how I knew I really had trained my daughter well on the pain scale. Okay, so what you need to do with kids, many times it's okay to elicit the history through the mother or the father. And just make sure that you take and document that. Mother was in the room today. Mother says that little Johnny is having difficulty sleeping, that he's been complaining of pain in the neck area, and that he says and you try to put it in their words. Many times regarding the description of the pain, the kid isn't going to say sharp or shooting. They're going to come up with something. Document that. That's in their own words, and that's really powerful. So that's how I do it with kids. I work through the parents a lot with that regards.
Okay, we have 88% who have voted. If there's one or two more out there, if you haven't voted yet, and the pop-up is there for you, put in a quick vote. I'm going to close the poll in just a few seconds. Give everybody the opportunity. Okay. I'm going to close the poll now.
Okay. Well, for those of you that stated that improving the documentation is going to be the most important for the doctors, that is correct. Okay, so improving your documentation is absolutely the most important aspect for your office in order to transition into ICD-10. Now, following that is you need to have a good system or good resource or tool for you to document, and that's the reason I highly recommend you get into electronic health records. And then training for your CAs. All right, so we can teach anybody to translate a code into an ICD-10 code. But the question you have to ask, will your documentation support that code? And it's not just ICD-10. It really works right now with ICD-9. Would your documentation support the ICD-9 codes that you're using? And I can tell you from reviewing a lot of case files over the years that we have a problem with this in the profession. And you don't hear much about it, but this is going to be a weakness that will really expose us. We're starting to get some glimpses of how bad it is when Medicare does those reviews and they publish the error rates on our coding. And like I said, back in New York, their carrier, there's huge error rates on coding that are occurring. So it all is the doctor. Your job is to document what you see, tell the story of the patient, and then from those words we glean the most appropriate diagnosis codes.
Awesome. We've got another question about the pain scale. A doctor
Okay.
wanting to know if you use the FACES pain scale, 0 to 3 pain scale for HPI, or do you use the VAS pain scale?
I use the visual analog scale, but you can use a little smiley face, frowny face, anything that can objectify what the pain scale is. And actually, you need to have something because with the physician's quality reporting system, they're stating you need a standardized tool. All right, so that's measure, I think it's 131 for physician's quality reporting system. And just to go into that real briefly before we take a break, PQRS, if you're seeing Medicare patients, you should be reporting G codes on your Part B. It's only Part B patients. And you should be doing that now. I mean, if you haven't, you probably should get in contact with us so we can help you out with that. Because if you don't have 50% of your Medicare patients using the G codes for 2014, you're going to start having penalties in 2016 for your Medicare reimbursements. So overall, if you don't start, I take that back. For 2016, yes, you'll have penalties. You should have started really in 2013. And so if you didn't do PQRS on 50% of your Part B patients in 2013, you're looking at, I believe, about, I think it's 1% or 1.5% decrease in your Medicare reimbursements starting in 2015. If you don't start this year, you're looking at a total of 2%. So you're going to get 98% of their allowable payments. I mean, is 2% a lot? No, but geez, Medicare doesn't pay us a lot, you know, for what we do. And so these G codes are to establish, number one, I believe, and again, this is my personal opinion, I think that over the years that we have not graded out very well on reports from the Office of Inspector General. And so we've hit our chiropractic philosophy has butted right up against medical necessity. And so in an effort to reduce this, and not just us, it's all healthcare providers, the PQRS was developed. And so what they're really looking at, they want to make sure that, number one, that a patient has pain. And that's why you use a G code. And then the second aspect of this, and it's not coincidentally related to their medical necessity statement at all. The medical necessity statement, if you remember, patient must have a symptom, they must have subluxations causally related to that symptom, and the final piece of that puzzle is that they must have a corresponding decrease in their normal functional activities. Okay, so now what the PQRS system does, it holds us to that. So when you use those G codes, you're saying patient has pain. The next measure is a functional outcome assessment measure using neck disability or oswestry, and one of the codes says there is a noted functional deficit and there is a care plan associated with that. And then they came up with the new measurement, which is blood pressure, which is, there's a lot more to that as well. So all these things here are coming around to our physician's quality reporting system, stimulus, they're all interrelated. And I think with that, we'll go ahead. Denise, are we taking a 10-minute break then?
Do you have time for a 10-minute break, or is a 5-minute better for you?
Let's do a 10-minute break.
Okay.
I mean, this is, I know this information, you know, can be a little dry, so
yeah.
Go ahead and stretch a little bit, and
when we come back, there is another pain scale question.
Okay, sounds
okay.
good.
All
righty,
right.
We'll see you in 10 minutes.
Thank you. Okay, we'll be starting back up in about a minute if everyone wants to get settled at their computer. All right. Are you ready for Dr. Arkfeld?
I am here. I'm ready. Yes.
Okay, it looks like, okay, so our question is, if a child cannot tell you the pain scale, would you be falsifying notes by using the pain scale?
No, not if you document that you were obtaining this information from either the mother or the father or the guardian. Now, is a pain scale that important when dealing with a kid? No. And if you don't feel right about that, then just omit the pain scale, especially if it's a 0 to 10. You can always ask is it mild, moderate, or severe? All right, so you can rephrase it right there. Okay, moving right along. So again, our clinical examination, physical, the purpose is to generate a problem-specific diagnosis. Now, in chiropractic college, we were taught to conduct an extensive orthopedic evaluation on every patient. And when we get into practice, we realize very quickly this is not feasible or profitable. We can't run through 20 to 30 orthopedic neurological different tests and spend 2 hours with the patient. We don't get reimbursed for that time, and we just can't make any revenue off of that. And at some point, it's just going to be counterproductive. But now on the other hand, the exam forms that you would just check as positive or negative, that's not correct either. Okay, and so that's incorrect documentation on the interpretation of the orthopedic and neurological. So when we do that, when we take these shortcuts, and I realize it happens, we get busy and we start taking these different shortcuts. But when we take those, or we abandon orthopedic and neurological procedures, and I talk to a lot of doctors, and I've heard a lot of people say, well, I don't feel like the orthopedic or neurological tests really tell me anything. I've abandoned performing those tests. I do the subluxation station right now, or I do surface EMGs on patients, or I have my chiropractic technique that I rely on. And those are all excellent tools. But remember who's writing the paycheck when it comes from the insurance industry. And they don't understand our technique. They don't understand activator or Thompson technique. They don't understand the surface EMG or the subluxation station. What they understand is the medical model. They understand orthopedic and neurological tests. So I hope that I'll convince you after today to bring those back in. You're going to need to. You cannot substantiate ICD-10 diagnosis, and I would even say ICD-9 right now without using orthopedic and neurological evaluations. Over the years, I have performed at least 1,000 chiropractic file reviews. And the most common error found was the failure to properly indicate what a particular orthopedic or neurological test really was meant to elicit. So, for example, many doctors continue to mark positive on cervical compression tests, even if a patient stated there was only pain in the cervical spine. There was no radiation into the extremities. And that is not correct. There has to be a radiating component for our compression test. Another prime example is straight leg raise. there's a lot of inaccurate marking or false positives being marked down. This test is designed to assess for sciatica. It's a nerve stretch test, and too many doctors are stating hamstring tightness, or there really is hamstring tightness as a positive finding and not true sciatica. So if you're a little rusty on your ortho or neuro tests, I recommend go back and review them. Do you have to go back and take an exhaustive refresher course or read Mazion or Evans or anything? No, take the ones, and basically I'm going to ask you to look at the compression test. Our cervical compression, foraminal maximum compression, shoulder abduction, cervical distraction, Kemp's test, and straight leg raise. I'm going to take you to really look at those in order to determine what they are meant to elicit and then how to document those. If you want an excellent textbook on how to conduct a thorough exam, there is one by Dr. Jeff Miller, and I'm looking for it right now. He has an excellent, where is that? It's how to conduct a very thorough orthopedic. Dr. Miller used to do a lot of work for foot levelers, and he publishes a lot of, oh, here it is right here. Okay, it's the practical assessment of the chiropractic patient, a thorough orthopedic and neurological examination in less than 10 minutes by K. Jeffrey Miller, D.C., DABCO. This is probably one of the best orthopedic flows that I've ever come across. And I used what he has recommended. I've used for years. And so I'm not sure that the book is still in print, but I always reference it. And if any of you have ever had a chance to listen to Dr. Miller lecture, he's excellent, and above all, he's just a super nice guy. I've had the pleasure of meeting him a couple times, and he is just a super guy. Real credit to our profession. So what he's done is he's broken down the assessment, how to conduct in a real nice flowchart manner your orthopedic and neurological tests. And a lot of times when helping my compliance clients out in using their EHR, one of the first things I ask them is, do you have any kind of an examination flow? And I'm surprised. A lot of them still say no. I just kind of wing it. And it really helps if you have a flow. And so, like for mine example, I start all my exams out standing, and I do certain tests standing, then I go to seated, then I go to supine, and I end with prone testing. So you need to really develop a nice flow so you don't forget anything. But with ICD-10 coming up, we have to nail these orthopedic tests and the neurological. So it's imperative that you understand what you're doing when you're applying these provocative maneuvers, and you need to know what the anatomy involved in the region of complaint, the neuromuscular system, the biomechanics, and the reasoning behind each of the orthopedic and neurological tests. And then how to perform them, how to do it in a very easy flowchart way, so you can do it quickly. And one of the things Dr. Miller's text talks about is how a lot of the tests really mimic one another. For example, cervical range of motion. If you do cervical extension and the patient has restricted extension and talks about pain localized in the cervical spine, and they may even point to a facet joint. And then you do a right rotation and they point to the right, let's say C5, C6 facet joint. And then you do right lateral flexion and they say, I've got pain right here, and they point again to that same facet joint. Well, what you're really doing is a compression test. You're compressing that facet joint and quite possibly even the disc. So when you apply any compression test, you're probably going to get the same result as your range of motion. and then you come in and you do a distraction test and it relieves the pain, now you've isolated. Now you can say, you know what, maybe this is a facet syndrome, maybe this is a posterior disc, and because now it's all localized pain. Remember, these compression tests were designed to elicit radiating pain. So when you can do that, when you start thinking of all these tests and you do enough of the same type of tests and counter testing, now you can take and objectify the subjective responses from these orthopedic tests. Because another knock on the use of the ortho test is that doctors would say, well, it's all based on a subjective response of a patient anyway. How do I know they're telling the truth? Well, you know, that's correct. But you do enough of those tests, enough of the different tests, and you get the same answer, now you're starting to quantify it a little bit. You're objectifying it. So when you're doing that, you're also thinking about the pain producers. And that's what we call tissue differentiation. It's a term for narrowing down or isolating the anatomical structure or structures causing the pain or the symptoms experienced by the patient. And this is crucial for ICD-10. It's also something you can start right now in your offices. So when you rush through the exam, often there's inadequate interpretation and documentation of those exam findings. And then it leaves you searching for a code. Or maybe you just are so used to a specific code, and that's where these cheat sheets have come in, that you just go to the old reliable. And that is going to show up, especially in ICD-10. So I want you to start getting back to the basic fundamentals and doing tissue differentiation through a nice examination flow. So the examination flow actually can begin with the history, evaluating a patient as they enter the exam room. You're going to evaluate general appearance, then you have them go off and get their vital signs. You're going to look at gait and postural analysis, then you do your ortho-neuro testing, and then biomechanical evaluation or your technique, you know, or your surface EMG. You can do all those. Just make sure that you get the ortho-neuro tests in there. So with the process of tissue differentiation, this is where range of motion is really important. And please don't undervalue the information that can come from range of motion. So range of motion is going to, first of all, identify if there's injuries to two tissues, muscular tendinous, which is our contractile tissue. So it's going to say right away, do we have an injury in the muscle belly, musculotendinous junction, body of the tendon, or the tenoperiosteal junction? And the other aspect is passive tissue. Passive range of motion is going to let us know if there's a problem or the pain producer is with ligaments or maybe a facet capsule. And that's the reason O'Donoghue's test in the cervical spine is really a good test. And it's going to tell us both if there's contractile or passive tissue injuries. So when you use O'Donoghue's test, you're doing your range of motion actively, and then you do passive range of motion, and then you do resisted muscle testing, resisted testing in the cervical spine. So when you do those with O'Donoghue's test, not only are you doing the range of motion, you're also doing muscle testing. So you're determining, first of all, how the neurological structures are faring within the cervical spine, and if there's any kind of strain or sprain. So you're going to be able to start to differentiate a muscular injury, if there's pain on active range of motion, or if there's pain and resistance on passive range of motion, a sprain, ligamentous injury. So pain that is present primarily upon passive range of motion, especially at the ends of specific joint range of motion, that indicates ligamentous structure injury. I do not like strain sprain diagnosis. I mean, you can use those in some, but I think we've become way too dependent on those. The only way to definitively state there's a strain sprain is you have to perform active range of motion and you have to perform passive range of motion. If you are not doing that and you're using that diagnosis, those tests do not, you do not have the objective findings to validate that diagnosis. I would record the plane that produces the pain because, again, active range of motion stresses both contractile and passive tissues. Pain that is produced during passive but is absent during resisted may indicate articular structure or posterior joint capsule injuries. What do those equate into? 724.8 facet syndrome. And facet syndrome isn't just for lumbar spine. I think there's a lot more of those that are occurring post-traumatic injuries, car accidents, and we're seeing they're strained sprains when they're really facet joint injuries. And that's the reason these patients are not, there's not good outcomes with them, you know, because it wasn't a simple strained sprain. It was more of a joint injury as well. So just a refresher, diagnostically again, pain on resisted motion. So if there's pain when you're doing the muscle testing, that's musculogenic. Pain on passive motion, especially in motion, is ligamentous. And then if you have pain during active and passive, but it's not increased with resisted, it could be considered articular. And that's where the history comes into play, because you have to determine the mechanism of injury, and if everything is leaning towards a facet syndrome, now you have it. Also remember, there are no normal range of motion references. There's just too many variables here with gender and age variations. I know that a lot of doctors like to, when they do their range of motion studies, they like to put numbers or percentages. I don't recommend that. I've seen that come back to haunt doctors in post-payment audits with the administrative law judge asking how the range of motion was performed, or in depositions. If you really are into numbers, I highly recommend JTech Medical. They have computerized range of motion and muscle testing, and they have the AMA guides to the evaluation of permanent impairment. That's the addition. So the protocols for obtaining numbers is really based on using digital inclinometers. That's the most appropriate way to do that. Okay, if you do not have digital inclinometers, then instead of using numbers, just say that you visualize active and passive range of motion. And so some of the verbiage that you could use would be as follows. Range of motion was performed actively, passively, and was visually assessed. All movements were unrestricted and pain-free in the cervical and lumbar spines. Or if it was abnormal, range of motion was performed actively and passively and was visually assessed. All planes of movements were restricted and painful in both cervical and lumbar spines. Okay, so getting into the orthopedic tests again, make sure you know what you're doing, and so you may have to go back and review those. Document them. So the compression test should indicate if the pain producer is arthritis, dural irritation, intervertebral disc syndrome, facet, or nerve root-mediated pain. That pretty much covers a lot of our pain producers, right? And that's just with our compression test. Okay, so if you have a negative compression test for radiating complaint and you're just putting negative, you're missing out. So here would be a great way to document this because we can tell if it's facet joints or posterior intervertebral disc. So let's look at this. The cervical compression test was found to be negative for radiating pain into the upper extremities, but did elicit localized pain in the C5 through C6 facet joints bilaterally. So if your extension range of motion was elicited pain here, range of motion, right lateral flexion, right rotation, and you did your compression test, Now you do distraction and they go, ah, that feels great. Now you know that that was a facet joint problem. And it gives you the medical necessity to perform manipulation and distraction. Other correct verbiage for this, and you can use this for the Kemp's test as well in the lumbar spine. Cervical distraction was positive for relieving the radiating pain of the upper extremities. Cervical distraction was positive for relieving localized pain. Cervical distraction was positive for muscular pain. So you see how our ortho tests can go through and really substantiate what we're going to be using diagnostically. And again, the main compression test in lumbar spine is Kemp's test, and it has its share along with cervical tests with false positives. So just make sure, here's our correct verbiage for this. Kemp's test was positive for radiating pain to the right lower extremity. Kemp's test was negative for radicular component, but did elicit localized pain in the L4, L5 facet joints on the right. And then Kemp's test was negative for radicular component, but did elicit localized pain in the L4, L5 facet joints on the right. When performing on the test on the left, the pain was diminished. Well, you opened up those facet joints. That was like a distraction test for these. Okay, so this becomes a very valuable piece of information for a negative test. I'm going to get through this kind of quick because I do want to get into the vertebral subluxation complex here. So just remember, your clinical impressions, the diagnosis, they must be supported by the patient's subjective symptomatology, mechanism of injury, objective findings, and then bringing it all together are other diagnostics. Maybe it's X-ray, maybe it's MRI, maybe it's CT scan. One of the things you do not want to be using, these are incorrect diagnoses. This is not headache and neck pain. Okay, this is a neurological dysfunction of the upper portion of the spinal cord, lower portion of the brainstem, and associated suboccipital nerves. So please abandon using this in place of common head and neck pain. And the same thing with cervical brachial syndrome. This is also called brachial plexopathy. So if you have neck and arm pain, there's other more appropriate codes that you should be using, such as brachial neuritis or radiculitis. Okay, so you need to make sure that you're performing a neurological test, and there must be either motor weakness on your muscle testing and or sensory loss with your dermatome testing to come up with a neuritis or radiculitis diagnosis. Now this term is going to be replaced with radiculopathy in ICD-10. And the same thing here with our 724.4.
We do have a question.
Okay.
And maybe I'll do the next poll while the questions on the next poll is about tissue differentiation. Is this
okay?
Is this okay to do that one?
Yes, it is.
Okay. So everyone hold down your CTRL key. I'll launch the poll now and give you a few seconds to vote on it. So while we're getting this question answered. So speaking of car accident, would you recommend using as many diagnoses in field 21 to describe each chief complaint, or continue with 4-point diagnosis?
Excellent question. And I would say you use as many diagnoses that is going to pertain to the condition or conditions the patient presents with, and you can validate on your history and examination findings. And especially with auto cases, I don't see where 4 diagnoses sometimes is going to be enough with those. But you also don't put in fluff diagnosis like stiffness in joint or other sacral disorders. Those are what I call fluff. They don't really mean anything. You want to try to get to the most specific diagnosis that's going to describe the condition that you're going to treat. I remember years ago sitting in a neurological seminar, and it was an MD neurologist, and he said they try to get to a mono diagnosis, one diagnosis that fits the neurological syndrome or whatever that the patient is experiencing. We can't do that as chiropractors. We have too many things going on because we're treating neuromusculoskeletal. So get to the most specific diagnosis. And you know what, right now, start doing that with ICD-9, and believe me, it's going to be made much more easier with ICD-10.
Okay, we only have 90% voted, so that tells me there's 3 or 4 out there who need to put a vote in. So even if you don't know the answer, put your vote in, because it helps me know you're behind there for your CE credit. If the poll didn't pop up for you again, type it into the questions box, email or fax it to me, and then I'll know that it was you and that you were there. So that being said, and giving plenty of time for answers, I am going to close the poll.
Well, if you did not state anything regarding cells, you were correct. Okay? Tissue differentiation is all about identifying the anatomical side of pain. All right, moving right along here. So our motor and sensory evaluation, if you have a patient that presents with radiating complaints, you have to do a neurological exam. We're the pinched nerve profession, right? Okay, so let's do our neurological exam. Do your motor evaluation. You can run through these really quick. You can get through these very quick. Lower extremities, because here's what's going to happen in ICD-10. You're going to be called upon now to identify, sometimes what level. Is it mid-cervical, lower cervical, especially with disc problems? So you really need to nail this down and get back to doing this really well. Sensory evaluation, you're going to be determining if the sensory component of the dorsal root ganglion is being irritated. Okay? And if you don't do these, you're not performing a complete exam. Actually, dermatome assessment terms are going to come back in because there's actual ICD-10 codes for each one of these. So you want to be able to document this. All right, my favorite. This is where we're going to bring this all together now, because we're going to talk about what we treat as chiropractors. We have 5 components: spinal kinesial pathology, neuropathophysiology, myopathology, histopathology, and pathophysiology. Spinal kinesial pathology, the abnormal movement or position of a vertebrae. When we have restricted range of motion on active and passive, when you do motion palpation or static palpation and postural analysis, patients come in with antalgia, you have spinal kinesial pathology. Okay, so now what I want you to start thinking of is that when you use these 739 codes or the 839 codes, we're going to break these down into the individual subluxation components. So what I want you to start thinking of is what component does the patient have? And basically what we're doing is that we are taking our subluxation components and we're tying them in clinically and putting them into the most specific diagnosis. So when we have negative compression tests for radicular symptoms, but there's localized pain, that's spinal kinesial pathology. So what codes support spinal kinesial pathology? Our 739 codes, our 839 codes. Our facet syndrome, 724.8, our muscle spasms, our myalgia, our stiffness of the spine, of the joint, torticollis, acquired deformity of the neck, just to name a few. So you see how, like facet syndrome, these are, I guess, if you want to break this down into chiropractic diagnosis, which would be our 739s and 839s, and medical diagnosis, You see where our ortho tests now are supporting a medical diagnosis of what we treat? Here's our ICD-10 now for 739 segmental dysfunction. Spinal kinesial pathology and our traumatic subluxations. Again, remember the last character is the episode of care. We're going to find this on our traumatic subluxations. Okay, we went through these last week. All right, now neuropathophysiology, the abnormal function of the neurological system. This is what we are as chiropractors right here. It's what we treat, you know. And what I've seen is no neurological exam, but yet a radiculitis, which you can't do. So in order to substantiate neuropathophysiology, we have to have motor and or sensory findings, and then that's going to equate over to brachial neuritis or radiculitis. You know, I put the cervical brachial syndrome and cervical cranial syndrome. You better have some hard neurological findings for those. And then down in the lower extremity, sciatica or lumbosacral neuritis or radiculitis. So again, this is validating, these codes here are validating neuropathophysiology of our subluxation. And here's our just a few of our ICD-10 seminars or diagnosis. So do you see why we have to get back to isolating the nerve roots? Because now, where's this radiculopathy coming from? Is it the cervical region, cervical thoracic region? So we have to name it by site. And then if you have, let's say in the absence of motor loss, and patients do not have any disturbance in dermatome testing, no findings, you know, you can use 782 if they just say it's a paresthesia, you know, but they can't, there's no neurological findings. And then ICD-10, we have all these others right here too. And we get back to our assessment terms. Myopathology, pathological changes occurring in the spinal musculature. Okay, so how do you prove myopathology beyond palpation? Decrease active range of motion, pain on active range of motion, antalgia. Now we get into muscle spasms, muscle hypertonicity, muscle wasting, muscle weakness. This is all myopathology. Can muscle weakness be due to neuropathophysiology? Absolutely. The nerve is being irritated and it's causing corresponding muscle weakness. And these are some of our codes right now, the 7 or our ICD-9 codes that you can use to support myopathology. If you are using passive therapies such as ultrasound, electrical muscle stim, I would even say laser therapy, if you have massage therapy in your office, or if you're a active release technique, you need to have a myopathology component into your diagnosis. In other words, you need to have a muscle spasm or a myalgia into your diagnosis to support the use of those codes. And then we have our ICD-10 codes right here that correlate. Histopathology, abnormal soft tissue function. Okay, this is going to be our facet capsules. This is going to be our disc. This is going to be our ligaments. You know, so how do we associate this with our ortho test? Pain on passive range of motion. Our orthopedics test designed for disc pathology. Valsalva, straight leg raise, Bechterus. You know, and then that's going to just be confirmed with X-ray and MRI. So interesting, some of these ICD-9 and eventually ICD-10 have multiple subluxation components. So facet syndrome, there's an irritation spinal kinesial pathology, and it also can be histopathology. And then we have some of our correlating ICD-10 diagnosis. Now we have the strain sprains also. And you'll see in ICD-10 we have that 7th character because they're saying this is a traumatic diagnosis. And that's where, you know, I want you to really try to get away from that, because if you don't have a history or a mechanism of injury that supports a trauma, I'm not so certain you can use a strain or sprain in the cervical or lumbar spine. Interestingly enough, the research has shown now that patients presenting with low back pain or state, you know, I just strained my low back, or I've had frequent episodes of strains in my low back, it was just the musculature. They're finding out now it wasn't the musculature. It's little tears in the disc. And that's the reason these little tears that happen, and it causes them pain right away, and then it goes away. And then all of a sudden they're bending down to get the pickles in the bottom of the refrigerator, and they can't get back up. You know, so it's really more than soft tissue. We're talking disc problems now. Pathophysiology is the abnormal function of the spine and body. And this is going to be all our degenerative processes, all arthritis. You need to have X-ray, MRI, or CT scan, but you need to have validation by X-ray, MRI, or CT scan. You cannot make this diagnosis on the clinical findings alone. So if you're going to use these diagnoses, and I'm amazed at the doctors that do take X-rays, it's in their X-ray reports, but for some reason they leave these diagnoses off. Get those on. Get those in your ICD-9 right now, and then get ready to use them in ICD-10. These are conditions that may require you to see the patient for a longer duration of time. It's going to take a little bit longer to get this under control. Are you ever going to cure this? No. These are chronic conditions. And please don't get hung up on the word chronic or be scared of it. If you treat Medicare patients, we treat chronic patients. You know, Medicare's definition of chronic really means that the patient's not going to get any better. They're stable. Our definition is structural. They have a chronic structural condition, but they may have a flare-up. They may have an exacerbation, an acute exacerbation, because we know that structure can't handle the stresses that normally would be placed upon it. And here's our other pathophysiology diagnosis.
We do have a question.
Sure.
How do you show change in the disc degeneration diagnosis for Medicare?
You don't. You really don't. We don't, as far as MRI or X-ray, there isn't going to be any change. You're not going to, I know there was talk in years past of altering or reversing the arthritic process, but as far as Medicare is concerned, they don't care about that. What they're concerned about is that your treatment, and this is why you have to use objective measures, that your treatment is, one, either reducing or eliminating the pain of the patient, and two, increasing or restoring to normal the functional activities of the patient. So irregardless of the condition, the only thing the condition or the diagnosis is going to give you, a more severe diagnosis such as spondylosis without myelopathy or radiculopathy or what that'll give you, it'll give you a longer time frame to get that patient under control. But once that patient is plateaued or you've decreased their pain or eliminated, then that's when you have to release them from active care. That's what Medicare wants. All right, so you see why I get a little excited? Not bad from a guy that graduated from Northwestern, because this subluxation complex just, it plagued me. You know, I was like, how do I, what I'm seeing clinically, how do I put that into the subluxation complex? And then how do I even have tests to support this? And quite honestly, I didn't come up with this. I put codes to it, diagnosis codes, but years ago, Backtalk Systems had a wonderful, a very nice thing with the 5 components. And all I did was basically put some ortho tests and then where clinic met the coding. Okay, so let's go through real quick here a case example. This is what the documentation is going to have to look like. For all of you that are wondering, Matthew Stafford is the Detroit Lions quarterback, and no, he is not a patient of mine. Okay. All right, so the patient presents today with the chief complaint of neck pain, secondary complaint of headaches. He stated that while playing Sunday, he was struck helmet to helmet by a very large defensive lineman. He felt immediate pain and was somewhat disoriented until he got to the sidelines. He also began to experience dizziness and mild nausea, but did not vomit. Since the game, he had constant neck pain and headaches. So subjective, today, so here we get into our history of present illness. He is experiencing constant moderate pain in the area of the cervical spine, restricted movement, stiffness, sore, tight pain in the neck. He finds that nothing makes his neck feel better, and it seems to be aggravated by repetitious movements, turning the head left and to the right. He also reports he is experiencing constant moderate head. He further describes it as throbbing, pounding pain generalized in the top of the head. Mr. Stafford related that resting gives him relief, but finds that light and fatigue cause more distress. He rated it as a 6 in the neck, 5 in the headache on a 1 to 10 scale. Review of systems. He has disturbed sleep, double vision, and nausea. Denies any significant past medical history, no family history. Social history, he was reviewed and found to be consistent with previous findings. Now we get into our neck disability index, and what this does is it relates how his condition is affecting his normal activities. So you'll see down at the bottom, he was given a score of 50. So he's really hurting. This has a severe disability on his life. And this is the reason I highly recommend clinical assessment outcomes. Anytime you can get to numbers, and when these numbers start to go down, you're providing the medical necessity for your treatment. General appearance, he's a poorly appearing 25-year-old male in a moderate amount of distress. He was awake, alert, and oriented, and in moderate pain. He showed good eye contact. He appeared comfortable, but is moderately depressed. He showed normal grooming and appropriate dress. We have our vital signs, postural analysis. Range of motion was performed actively and passively, visually assessed, and was decreased movement and pain on all planes. Our orthoneural, okay, so compression test was negative for a radicular component, but elicited localized neck pain. That makes sense. He took a hit to the helmet and probably really jammed the facet joint. Same thing with Jackson compression test, and then cervical compression or distraction, was found to be positive. It relieved the pain. Neurologically, because he had a concussion, we did cranial nerve tests, reflexes, all those were normal. Dermatomes were good, so neurologically he's doing good. Spinal exam findings revealed severe joint restriction at C1, 2, and 5 through 7. On palpation of the spinal segments, there was strong pain level at C1, 2, and C5, C7 bilaterally. Palpation revealed severe spasticity of the suboccipital muscles and cervical paraspinal muscles bilaterally. So here's what I came up with the diagnosis. This would have been a work comp injury. It was a traumatic, so I led off, here in Michigan we have to do the subluxations first. So I started off with 83908, closed dislocation, multiple cervical vertebrae. He had a concussion with no loss of consciousness, and then he had 723.8. That is actually going to be a facet syndrome affecting cervical region. He had muscle spasms, cervical spine pain, and headache. So these can all be validated by the history and by the examination findings. Now let's get into ICD-10 for the same thing. We led off with S13-101A, dislocation of the cervical vertebrae, initial encounter. So that A will fall off and it'll be replaced with a D on his next visit. Now we have a concussion without loss of consciousness, initial encounter also. And we have our facet syndrome, which now is called dorsopathies of the cervical region. We have muscle spasms, cervicalgia, headache. Now the etiology diagnosis is striking against or struck by a football helmet. And so we had to talk about what caused this. And also, do you notice the A at the end of that? Because that's going to be the initial encounter. So every one of these episode of care or traumatic diagnosis, that A will come off on the next visit. So this etiology here plays a very important role because it talks about the causation of his condition. Okay, we have a 58-year-old male presents to ABC Chiropractic for an initial visit. He is a long-distance truck driver, 25 years, complains of lower back pain, right leg paresthesia while sitting after he gets home from driving an 8-hour day. So again, range of motion restricted on all planes, pain noticeable on extension and right lateral flexion. That's pretty much a Kemp's test as well. Right lateral flexion reproduced the pain into the right leg. Okay, well, that's a Kemp's test. Well, Kemp's test is positive here. We have dermatome testing for hypoesthesia in the L4 dermatome, and left was negative. And then we have radiographs reveal spondylosis in lumbar spine. So based on this right here, ICD-10 really incorporates a few diagnoses from ICD-9 into one. We have M4726, other spondylosis with radiculopathy lumbar region. The radiculopathy is supported by the neurological tests. Spondylosis is supported by the radiographs.
I have a question.
Okay.
How long do you need to continue diagnosis with the etiology diagnosis after the initial visit?
Let's see here. I got to pull that question up. Okay. How long do you need to continue with the EDO? Oh, okay. You would continue with that EDO. That stays. That diagnosis stays throughout the rest of the course of care. Now, there are associated diagnoses with that etiology, and we haven't got into that yet. If you were treating an auto accident, you would have what type of vehicles involved. That would be the etiology. And then there's associated, where did it take place? Was it on a residential street? Was it on a county road? And what was the, what do they call that? The activity at the time. There's other etiology diagnosis that will actually fall off after the initial visit. But to answer your question, the etiology diagnosis will stay, and it will be the last diagnosis on your claim form. All right, real quick, we'll do one more case example. This actually was a patient of mine. She works as a bank teller and stands on her feet 4 to 6 hours at a time. Okay, so she was reporting moderate pain in the lower back, and she also has upper back pain, and she also a lot more uncomfortable due to exercising, and she's also having some neck problems as well. So we have our pain scale here, and we go through all the history of present illness here. And then past medical history. Now this, I put this in red because this was a girl that was in college, actually was going to a junior college, and I treated her in December of 2011 when she came home for Christmas break. And she hit black ice and rolled and hit a tree. And I treated her for about a month while she was back, and she was a basketball player. Then she went back to the junior college and finished out the school year, and I didn't see her again for a little while. So now she's returning after this time with neck, upper back, and low back problems now. Okay. So I put this in because this could be significant. We may want to use this if we were going to use a residual or sequela diagnosis. Now, I didn't, but that would be important there. So we have general appearance, vital signs. We have our range of motion again, so everything was decreased. Lumbar range of motion was decreased. And then we have our maximum cervical compression. So negative bilaterally, but elicited pain, C5, C7 facet joints. So what are you thinking right here? Okay, we're thinking facet syndrome, right? That would kind of play right into the past history and then our examination. So we're starting to think facet joint here. Low back was, we have Eli's here. So we got some left SI issues right here too. Neurologically, she's doing great, so there's not going to be a neurological diagnosis. However, on spinal palpation, there was focal pain, and she took her fingertip and pointed right at C5 through C7 spinous process and said, this is where it hurts. And she said, if you take your finger and go right here, and she said T1 through T4, that's what hurts. There wasn't a general area. It was a very specific area. And so that's going to be a different diagnosis, as you'll see. So I did not want to bring up causation. Here in Michigan, we could have reopened up the car accident, but she went away and played basketball. I hadn't seen her for a year or so. So causation would have been kind of sticky right there for what she's presenting with. So I went with these diagnoses right here. I've got my structural, then I have my soft tissue. Now that focal, when she pointed to a C5, C7, that was spinal enthesopathy. And if you remember Sharpie's fibers attach the muscle and tendon into the bone. Okay, so if those Sharpie's fibers become disrupted a little bit, you have spinal enthesopathy. So it's a soft tissue diagnosis. So we have that right here. And then we have our dysfunction of thoracic mild fasciitis, cervical facet syndrome, okay, down here based on our ortho test. Then here's our ICD-10 that we're going to look at. So M9903, 0504, and this is because her main complaint, chief complaint, was low back. So I'm taking care of all the low back diagnosis. So I do structural, soft tissue, and pain. Structural, soft tissue, and pain, because thoracic spine is secondary. Structural, and pain for the cervical spine. And then if I did want to put in the etiology would have been V47O2XS, driver of other type of car injured in collision with fixed or stationary object, non-traffic accident, hit black ice and hit a tree. So that would have been the most appropriate diagnosis if I was to put an etiology in there. perfect timing. We're at 1 minute over. Any questions?
I don't think there's any questions. None came up.
All right. Well, we have 2 more sessions, and then you guys are all ready for ICD 10, right?
Absolutely.
All righty.
Thank you so much, and thank you everyone for attending.